Thank you for listening to this PYA webinar recast. PYA is pleased to offer this alternative way to access our thought leadership. This is a recording of a previously delivered webinar. The information is accurate as of the date of the original event. The video recording, slides, and associated material for this and all PYA webinars are available on our website at pyapc.com. This podcast is for educational purposes only. It is not intended to be used as legal advice or an official opinion.
Good morning, everyone. Welcome to the latest episode of PYA's Healthcare Regulatory Roundup webinar series. Today's topic is the 2025 Proposed Rules Part 2, Medicare Physician Fee Schedule. This is part 2 of a 4-part series focused on the proposed rules. PYA is happy to present today's webinar on this important topic. You may submit questions during the webinar by typing a message into the questions pane of the control panel. Also, immediately following the end of the webinar, you'll be asked to complete a short survey and submit any additional questions. We will respond to the questions posed after the webinar via email. We've posted in the handouts pane of the control panel a PDF copy of the slides for your reference. Also, you'll receive an email later today with a copy of the slides and a recording of this webinar. With that, I would like to introduce our presenters, Martie Ross, Valerie Rock, and Miriam Murray.
Thanks, Jennifer. Good morning, everyone. I'm excited to be with you today to discuss this important topic. If you recall, back on July 10th, we did a webinar on the first of the proposed calendar year rules, primarily focusing on the outpatient prospective payment system rule. At that time, we thought we could cover the Medicare Physician Fee Schedule in one session, and then we actually looked at the rule and realized it was going to take a little deeper dive. So we've expanded this out to a 4-part series. As Jennifer mentioned, all of our webinar recordings, including the slides, are available on our website, including all 74 prior episodes of Healthcare Regulatory Roundup. This is our 75th webinar in this series. It's our diamond anniversary. We go all the way back to May of 2021. But today we're going to start in on the Medicare Physician Fee Schedule. You'll see here the 5 topics that we will address. And remember, this is a proposed rule. This is not a done deal. And really our purpose today is to help you identify topics for which you could comment, that we believe are the most relevant, the hot topics, where we think CMS could use your wise counsel on how to put these into final form. The comments on the rule are due September 9th. Now it's interesting because the rule actually published in the Federal Register this morning. And you see here my screenshot from my computer of the front page of this document. It weighs in at 1,053 pages of, yes, 3-column, 8-point font. It is dense. There are many, many topics here. But part of the reason we wanted to show you the screenshot is that green box that says submit formal comment. I wish they would take the word formal out because this is actually a very informal process. It does not need to be on official letterhead. It does not need to be formatted in a particular manner. Comments can be very brief. The only thing that they insist you do is to include the file number on the comments so they know how to appropriately categorize it. We also recommend that at the top of the comment, you reference the specific subject matter that you are addressing, because that's how they farm them out to the different CMS individuals who are responsible for that content. So you will hear all 3 of us come back to this idea of this is really a good idea to comment several times. So I get to begin the show discussing the cut in the payment rate. And if you have seen any headline about the Medicare Physician Fee Schedule proposed rule for 2025, it has been CMS proposes 2.8% cut to physician payments because that is, in fact, the reduction in the conversion factor for this year. But I'm going to take some time to go back and talk about how we got here, because I think it's very critical to understand this perspective so that you can be actively participating in the conversation around it, because there's part of this cut that is simply something for Congress to handle, and there is a part of this that is in fact impacted by CMS policy. And you need to understand the two, I think, to really focus in on where you comment and where you advocate to Congress on changes. So we're going to go, but before we get in deeper, I apologize. As we said, there will be a part 3 and a part 4 of this series. On August 14th will be part 3. You see there the topics to be listed. And on part 4, a week later on August 12th, we will delve into the topics including the quality payment program and MIPS, as well as changes to the clinical laboratory fee schedule. That's how broad this rule has become. There's just, I think I counted there are 31 separate sections in the proposed rule. We're not going to cover everything, but at least try to hit the highlights for you all. Okay, so let's talk about the payment reduction. And we're going to go back to 2015 to the Medicare Access and CHIP Reauthorization Act, or we lovingly refer to it as MACRA, or sometimes we refer to it as mackerel because it's become a stinky fish over the years. But at the time, in 2015, it was a hot deal. It was incredible bipartisan support for this legislation. You see the numbers in the House and the Senate. And if you remember back to 2015, that was sort of the beginning of not having a lot of bipartisan action going on in Congress. But this one was overwhelmingly supported. The reason was because Congress was sick of the SGR. You have been in healthcare for a while. SGR still makes you cringe. The sustainable growth rate was the formula that had been put in place back in 1997 to determine the formula for payment of under the physician fee schedule. And it was great from 1997 until about 2001 because it was actually generating some increases in the conversion factor. But in 2021, because SGR was tied to gross domestic product, it started resulting in cuts. And some of those cuts became very, very significant to the tune of 25%. And so every year from 2021 through 2014, we would go up to Capitol Hill and say, Congress, you need to intervene. You need the doc fix, as we started calling it. And every year that happened. And so MACRA was considered the savior of this because we were finally going to get rid of the doc fix. We're going to have a permanent system that worked. And it probably worked pretty well for a while. But briefly, let's sort of give you some perspective on MACRA. It took the then current conversion factor and said, for the next 4 or 5 years, from 2015 to 2019, each year we're going to authorize a 0.5% increase in the fee schedule. So if it was, the fee schedule was $10, it was going to be $10.50 the next year. I think I did the math right there. No, I didn't. Be $1.05 the next year. Sorry. That's why I have you, Valerie, to keep me honest on the math. And then the rule said 2020, which seemed like 100 years in the future, from 2020 to 2025, there'll be a 0% annual increase. That's where we are right now. So the fee schedule at $1.05 would stay $1.05 the next year. And then it proposed that beginning in 2026 and going forward, they're going to be a split on the increases in the conversion factor. If you are a physician or practitioner that participates in an advanced alternative payment model, then you're going to see a 0.75% increase in the conversion factor. If you're everyone else, you would see a 0.25 increase in the fee schedule. And that was to incentivize participation in advanced alternative payment models by practitioners. Because the other thing MACRA gave us was MIPS, or actually the quality payment program, which is both MIPS and advanced alternative payment models. And if you recall back between 2015 and like 2018 was the period of time we sort of set up the MIPS program, got it operational, kind of was starting to understand how it worked. And then of course, COVID happened and we sort of went off the track for a couple of years. But that's where we find ourselves, thanks to MACRA. Now, a little deeper dive into how we actually get scheduled payments on the fee schedule. And I've referenced the conversion factor previously, but the conversion factor is a flat number we're going to multiply by something. And what we multiply it by is the assigned relative value to a particular code. The code describes the service. The relative values include work, so that's the professional component of the service furnished by the practitioner. The practice expense, which is the rent, the tongue depressors, the nurses, and everything else, and then the malpractice expense. And AMA's RUC committee generally is the entity that sets these proposed relative values, and CMS will review those to determine if they agree with them and improve them. So if I have a CPT code or a HCPCS code, it's going to be tied to a relative value. To determine the payment, then we multiply that relative value by a conversion factor. So RVU times conversion factor gives you the national payment rate. here's where I note that it's always different for anesthesia, just to note that it's different for anesthesia, and we're not going to talk about why it's different for anesthesia, but just to note that. The conversion factor is really, I always call it the pie slicer, because there's an amount of money that Congress has appropriated to spend on Medicare Physician Fee Schedule, and the conversion factor is just how we're going to divide up that pie among providers. So it's a dollar amount tied to a statutory cap. Again, as I referenced previously, we're now in the zero adjustment factor through next year. And this is where I get on my soapbox and say the problem with the fee schedule is unlike every other payment system we have, OPPS or IPS or skilled nursing facilities or home health or ESRD, all of those, they all have built into them an inflation factor. And so they have data they look at, and they calculate in the inflationary impact on the provider, and they calculate that into the model that determines payments. There is no inflationary factor in the Medicare Physician Fee Schedule. Whose fault is that? You look at Congress. That's nothing that CMS can control. Just like they did in MACRA, Congress would have to come up with a new formula that included a inflation factor. Our good friends at MedPAC, the Medicare Advisory Council that advises Congress, they have suggested that the fee schedule be adjusted annually by 1/2 of the Medicare Economic Index, which is the measure of changes in medical expenses, medical operational expenses. That would be an example of incorporating an inflation rate, but there is not an inflation rate. So everyone that's screaming that a 2.8% cut to physician payments when in fact we have 4% inflation or whatever it may be right now, doesn't matter because the formula doesn't allow for it. Now, Congress is the only ones that can change that. What CMS can do, however, is how it assigns RVUs, because the statute requires that if in its policy making, CMS results in an increase or decrease in total RVUs, such that it would result in Part B expenditures being more than 20 million than we would expect without that policy change, then it's CMS's job to adjust the conversion factor to preserve budget neutrality. The pie stays the same, how we cut it changes. So if CMS decides to add a whole bunch of new coverages, like I'm going to add, for example, last year, HCPCS 2211, G2211, that complexity add-on code, because they added that was a new benefit. It was new money being paid to physicians. They had to pay for that. And the way they paid for that was reducing the conversion factor. That's why we had that cut last year in the conversion factor. The other thing CMS does is it looks at misvalued codes. It says, well, this is what RUC assigned it, but we don't think that's really accurate. There's some survey data out there that seems that it's actually different. So we're going to change the value of the codes. That's what happened in 2021 when we did the significant revaluation of the evaluation and management codes. And that, again, also impacted the conversion factor because the more coverage we grow or the higher RVUs we assign, that's going to bring down the conversion factor. Now, a brief history of, model here that there's some more complexity to how exactly payments are made. This is my favorite explanatory chart that comes from MedPAC. So it goes through how we start with the adjusted fee schedule payment rate, and then how there are additional adjustments made for the type of provider you are, whether you're participating or non-participating in Medicare. There's a geographic adjustment for those that practice at HPSAs, and then of course our friend the Quality Payment Program, the adjustments it makes, and that's how you actually get to the dollars that show up on your explanation of benefits. But let's talk about what's happened with the conversion factor in the last 5 years, because it's fascinating. And you start back in 2020. Remember, 2020 is when we went to the zero adjustments under MACRA. Our fee schedule conversion factor at that point was $36.09. In 2021, proposed 2021, this is the middle of COVID, CMS releases the proposed 21 fee schedule, and it's a huge cut. It went down to $32.26, and almost all of that, well, except all of that, was attributable to adjustments that CMS made to coverage, because they wanted to expand the payments for evaluation and management services, and they actually first introduced 2211. So we went to Congress, and Congress said, we'll increase it. Consolidated Appropriation Act 2021 increased the revenue. 2022, things stayed relatively calm, the adjustment there. Then we had the proposal, in 2022, they adjusted to 3461 through legislation and back and forth, and you can study this in detail. But what we ended up with this year are actually two conversion factors. We had 2024A and 2024B. 2024A is in fact what CMS had proposed, the $32.75. Congress came back in March of this year and gave us a bit of a bump, a 2.93% bump, which took us up to 2024B, which is for all services furnished after March 7th of this year, are at $33.29. So what has CMS proposed? One more slide. So in perspective, keep skipping a slide, I apologize for that. So from 2021 to 2024, what we've ended up with is a $2.80 cut to the fee schedule, 7.7% over that period of 5 years. And you see down there, you can compare that to the Medicare Economic Index, which is the measure of inflation in the healthcare industry, seriously outstripping. Well, obviously we've seen cuts to the conversion factor, but in fact we see patients going up. If you just look at the value of the dollar, the difference between 2020 and today, the value of the dollar has gone down 25%. So we are asking physicians, of course, to do more with less as the conversion factor works out. So for 2025, CMS is proposing $32.36 fees conversion factor. Again, note anesthesia is different. That's 54-cent decrease compared to 2024B. That's a 2.8% reduction. How do we get there? What did CMS do? Well, in fact, it's what Congress did. Because if you go back to what they're referring to as the minibus bill, the Consolidated Appropriations Act of 24, that provided for a one-time 2.93% payment increase for services furnished within that time period. And very clearly, no doubt in the legislation, that increase was temporary, just through the end of this year. So that CMS started 2.93% in the hole when it calculated the conversion factor. Nothing they could do about that. Then there's the 0% adjustment factor mandated by MACRA. And then I think for the first time I remember, CMS actually has a positive budget neutrality adjustment of 0.05%. So actually they anticipate there will be fewer RVUs billed because of changes they made in policy. How do we get a positive budget neutrality adjustment? When in fact, you look at this rule, there are all sorts of new expanded coverage that's proposed. But CMS determined that these expansions listed here, that's just a sample, actually have no corresponding negative budget neutrality adjustment because they don't meet that $20 million threshold. What CMS did do that tripped that $20 million threshold was the changes that they proposed to payments for global surgery codes. And we're not going to discuss those in detail today, but what CMS expects through its policy change, which demands a more aggressive use, shall we say, of the transfer of care modifier, they expect that to result in significantly lower utilization. And that then drove a positive adjustment factor to the conversion factor, positive adjustment to the conversion factor. So that's the CMS impact, because the policy changes they made actually resulted in what they anticipate to be lower utilization, and thus you actually changed how you cut the fee schedule by increasing the conversion factor by that point, that very small percentage. So rather than 2.93, we end up with effectively a 2.8% cut. Now I have a question. As we will discuss in detail, we all know that the telehealth flexibilities that we enjoyed through the pandemic are going to come to a crashing end on December 31st of this year. Now, crashing end, let's of course modify that. What's happening is that the geographic and location restrictions will go back into effect, meaning you have to only services furnished to rural residents who are present at a facility will be covered. There's a huge exception there because as through the pandemic, CMS permanently limited those restrictions with respect to telebehavioral health services. So it's only now the medical services delivered via telehealth where we'll see those restrictions come back into the picture on January 1st of next year. But that's got to be a lot, right? And you have a little graphic here I took out of a MedPAC report that shows you how many telehealth claims CMS has processed, and it's been significant. A lot of services are now being delivered via telehealth. And CMS said, yeah, but we don't think that's going to have an impact on utilization because we expect that they'll continue to be furnished in person, that it's simply telehealth is a substitute for what would otherwise be an in-person visit. And so no impact on utilization, no budget neutrality adjustment. Wait a minute. This is a cake and eat it too issue because down in Washington, we have our friends at the Congressional Budget Office, and CBO is responsible for putting a fiscal note on legislation. How much is this legislation going to cost? And although the fiscal note for the telehealth extension bill has not yet been released formally, word on the street is that CBO is going to tag that 2-year extension of the telehealth flexibilities at $4 billion. Because in CBO's world, telehealth is new services, not substitutes for in-person services. So someone has it wrong here. Either CMS should be making a positive budget neutrality adjustment to account for that decrease in utilization, or CBO should not be tagging this legislation at $4 billion. Now, my choice is that CBO needs to figure this out because this has been the long-standing obstacle to actually making the telehealth changes permanent. But that is, I think, the advocacy argument we have here. Comment to CMS on this doesn't make sense. You expect that utilization changes, make a positive budget adjustment, or we lobby to Congress and say CBO is wrong on their $4 billion, and you don't have a pay-go issue with passing the flexibilities. So I think this is setting up to be a really interesting discussion that we're going to have in the middle of an election season. Not that anyone's paying attention, but it is critical because this is where the cliff we stand on is losing the telehealth flexibilities. So with that, I'm going to turn this over to Valerie to talk about deadlines for reporting overpayments.
Thank you, Martie. Speaking of other things that were not really highlighted in the CMS release, because CMS basically said, yeah, we're expanding telehealth, which Miriam's going to get into a bit here, but didn't really say, but we're about to fall off a cliff. We need to make sure we're seeing all the things in the fee schedule. And one thing that got tagged into the fee schedule that is a bit of a surprise is the 60-day rule. So Martie, if you want to move forward into the next slide. Basically, what we want to make sure that you hear is that at the end of the day, it's likely that nothing's going to change in the way that we have been doing things. So I want to make sure that everybody's very clear on what we have been doing and what is potentially changing, but really not a change for how we've implemented it. So back in 2010, when the ACA was originally brought forth this concept of the 60-day rule, we were then put on notice that we have to do overpayments, refunds within a certain process. And we have a process that we've all been following that was eventually finalized in 2016 in the fee schedule or in the final rule. But Part C and Part D have been kind of floating between, like, are we going to do this or are we not? And because of litigation, it's been a not. But in 2022, CMS put out a proposed rule to say, okay, we're going to lump everybody together, parts A, B, C, and D. Of course, parts C are Medicare Advantage and parts D is your drug payment model. And so we're going to redefine what reasonable diligence is, or basically take reasonable diligence off the plate. And we're going to tie it back to an FCA standard, which is the knowing or knowingly standard. The problem with this is that it basically takes away our 6-month period to investigate. So it's really key to understand what our 60-day rule process is. So if we think about it in 4 parts. We have credible evidence. So we start with the first piece is we have a potential overpayment or we've identified an overpayment. And that may lead to other overpayments based on the way that this overpayment came to be. Maybe we have other overpayments in our data. So that credible evidence may have come through a whistleblower, may have come through your hotline, may have come through an audit, internal or external, and now you're on notice that you have a potential overpayment. And then we all knew that we had 6 months to investigate that. So you have 180 days to investigate that overpayment. We may do a statistically valid assessment. We may look at our data. We may do other analyses to get to a calculation. So that calculation is that third step. So credible information, do our investigation, which is a 6-month process, a max of a 6-month process. And then we're going to hit our identification of that. And at the identification, when we're calculating that overpayment, then we have 60 days to refund that. What this proposed rule stated is that we're going to remove that reasonable diligence definition and put in this knowing or knowingly standard, which basically contracted or did not clarify that we even had a 6-month period to use to address this. Additionally, because of when the original rule was finalized, the information regarding the 6-month period was in the preamble, not in the actual regulations. So there was still a lot of questions about whether we could use the 6-month standard or not. So what CMS has done is tacked on to this 2025 rule, if you want to jump to the next slide, Martie, and said, okay, we're going to say, okay, we're going to use the reasonable diligence standard. We're going to allow you to do this investigation process, and you're going to have that 180 days. And what this does, though, is focuses on Part A and Part B, still leaves Part C and Part D out. And you can read all about the litigation that's happened that's created this, basically Part C and Part D not being a part of this process. But CMS still had to move forward with finalizing the 2022 rule, and it had not yet because of all of this back and forth that was going on. So now it's put this, proposed rule out there for us to comment and for us to say, okay, yes, we agree, we disagree, this is how we need to affect this. So really where we're at this point is we need to comment to say, yeah, we agree that we need to still have our credible information as our day one, our up to 180 days of our investigation period, where we're not, trying to lean on this FCA requirement of intent, which would basically, put us at harm because of recklessness. And that's the recklessness part is what is concerning to everyone. So really at the end of the day, we want to follow the same process that we did previously. So in the next slide, what you see is the actual, kind of language regarding, you're going to do this good faith investigation on the similar reason or cause of the original overpayment. And then you can, after that investigation is done and you've calculated that overpayment, which is where your identification time starts, the 60-day clock, you then have 60 days to refund that. So whether it's 180 days that you're doing your investigation, or when you have that final calculation, you want to make sure at that final calculation, you're on notice, you have 60 days to refund that, or at the time of your next cost report. So depending on, which angle that you're having to take there, because it's Part A and Part B, even though we're talking about the fee schedule and really talking about Part B generally right now, this is a Part A and Part B consideration. So, make sure you're commenting both from the Part A and Part B perspective, and stating that, that generally we would agree, because generally this is the same process that we've been following since 2010, and we're all in the same, manner and fashion. Why change it at this point? It is one thing that would be stable in our world, which everything else is not. So, I think it would be a good thing for us to say we're all on the same page. Let's use this investigation time period to make sure that we've truly calculated this overpayment. But also make sure that you have your processes in place and your policies in place to meet these requirements, to meet the 60-day rule requirements, because if you don't have those in place, or if that's not clear, this is a time to clarify that. This is a time to make sure that that you know when you're going to take something to the next level for an investigation and things like that. Where it becomes complicated is where everybody's not clear on when that next step is going to be made. I think we can turn it over to the next slide.
All right, that's me. Thank you. So now we're going to talk about advanced primary care management. Thanks. So CMS has introduced 3 new codes for advanced primary care management services. I'm going to shorten it to APCM just because it's easier to say. But what is the intent behind it? It's to encourage whole person, integrated, accessible healthcare, and to address the majority of a patient's individual health and wellness needs, and to create sustained relationships with the patient, with their family, and with the community. So what is APCM? I'll get it down here. APCM. They're care management services. So, okay, we've got care management services out there already. So what are these and how are they different? So these are very similar to CCM and PCM, where you have clinical staff performing the care management services at the direction of a single provider. But that single provider is the director, the focal point of directing the care for this patient, the primary care services for this patient. And these services are delivered on a monthly basis. So basically, the provider is the director of a cast of all personnel who are going to be providing services to the patient. It was developed based off of lessons learned from CMS's innovation care models, such as the comprehensive Care Plus model, the primary care first model, and they created the elements of APCM to reduce the administrative burdens that are currently part of our coding and billing rules. Some of the lessons they've learned are care coordination, team-based care, leveraging data to risk stratify their patients, including trying to reduce the inpatient or ED visits and increase patient satisfaction. So what does APCM do? Well, it's bundling many of the separately billable services that primary care providers are currently doing, such as CCM, TCM, RPM, virtual check-ins, and other communication technology-based services such as e-visits. So they have stratified APCM into 3 codes. Those 3 codes are based upon the number of chronic conditions and the enrollment as a qualified Medicare beneficiary, reflecting both the patient's medical conditions as well as their social complexity. So beginning January of 2025, physicians and non-physician practitioners who use an advanced primary care model of care delivery, yes, that's a mouthful, they can bill for APCM services if they are continuing to be the focal point of all needed healthcare services and are responsible for that patient's primary care services. It is very similar in many ways to CCM and PCM, as it also can be performed under general supervision of the primary care billing provider. There are some differences, such as there is not a time threshold applied to APCM services. Yes, I know, I saw the eyebrows go up. But there are a few additional elements that have to be performed or hoops to jump through. We'll go to the next slide. So what are the elements? The elements, if you look at these, and yes, they're in colors on purpose, the first 7 should look familiar. They are part of the CCM, PCM, TCM type of services that may already be performed by your primary care providers currently. And then the 3 at the bottom are in red on purpose because those are the 3 new elements that have to be part of APCM. To note, the comprehensive care management element is a key component of the delivery using the APCM model because those care management services have to be tracked, but you don't have to track the time or the minutes of the service. If a provider cannot perform all of these elements fully, and they do say fully in the proposed rule, then APC services should not be billed. So what does this mean for practitioner requirements? So in addition to the CCM, PCM elements that we just talked about, the practitioner should also furnish those other 3 elements. So what are those other 3 elements and what do they mean? So enhanced communication opportunities include various methods and technology available to communicate with the patient. This includes emails, patient portals, as well as being able to provide alternate ways to care for the patient using telehealth and performing home visits or e-visits if they're needed. What's the patient population level management one? Well, that's the ability to analyze the data and using that data to risk stratify the services based off of diagnoses, claims, what services are needed. Many providers that are in ACOs or are part of CMS's advanced care models, they already have this ability as part of their care model to focus their services based off of risk. So this is new for other providers. Lastly is the performance management element, and that element identifies key measures for improvement activities. And it is also, Medicare is proposing that this is a required element as a condition of payment for APCM. And you can meet those element or this element if you're a MIPS provider and reporting the clinical quality measures, which are foundational for primary care. And it holds the practitioners accountable for total cost and quality of care they provide. So a MIPS provider would report through the value in primary care MVP, and then you've got your other shared savings ACOs who also meet this requirement by their reporting through their ACO measures at the end of the year. So the APCM services encourages primary care practices to transform, to ensure that the patients have access to high quality primary care services, and it's intended to simplify the billing and documentation requirements. So what is it? How do you bill for it? So you have to be able to provide the advanced primary care delivery model. That's first. That means all of those elements in order to perform and bill for APCM. How do you know? Well, if you're submitting a claim, you're basically attesting that you comply with all of the practice capabilities. That's all of those elements. It's billed once per month. And only by a single practitioner who is the primary care person. They are responsible for that patient's primary care. It is not time-based, and all clinical documentation should be included in the medical record to make sure that you're supporting the services that you're providing. Also of note, APCM services cannot be billed by the same practitioner or another in the same practice for the same month as CCM, PCM, TCM, virtual check-ins, and e-visits, and there's a few others in there as well that they mention. However, you can bill for SDOH, social determinants of health, community health integration, behavioral health integration, and RPM. One thing to note is that the Medicare cost sharing responsibilities still apply. So patients need to be aware of that, and they would be when you do your consent, which is one of the key elements that you have to inform them that this is also cost sharing applies. So how are you going to get paid for this? That's a good question. And let me assure you, when I was reading the rule, I got lost in all of the numbers. It is interesting to read, but hard to follow. But basically, they are taking and mirroring historical CCM data or RVUs in order to calculate the RVUs for each of the levels of APCM. And then, of course, they use a conversion factor from 2024 to multiply times the RVUs to get to the national payment rate. So basically, an APCM level 1 is calculated as 2 billing units of a general CCM service, which is the 99490. Level 2 is 5 billing units of the general CCM code, the 99490. And then level 3 is more complicated. They don't make it easy, do they? It is based on level 2, but then they calculated the per patient per year spending on dual eligible beneficiaries and the per person per year spending for non-dual eligible beneficiaries. They calculated a difference and said, okay, that's the percentage, which by the way is 218%. I'm telling you, it was bizarre. And then they calculate that out on the work RVUs to come up with the national payment rate. So level 1, $10 per month, level 2, $50 per month, and level 3, $110 per month.
It's interesting, Miriam, that level 2 is like $12 less than CCM reimbursement. And their logic is you don't have to do the time requirements, and that's should be the difference in the practice, expense. Is it in there, or?
It doesn't really address that, but it does ask for comments, which it asks for comments throughout the ACPC or APCM section, because I think they are still working to try to tweak this program and make it beneficial for our patients to receive these types of services. I think they generally are trying to do the right thing. How we get there is going to be interesting when this becomes final.
Mm-hmm.
So
just for those of you that are like me, that say the first thing you get the fee schedule is you see what they did with chronic care management, you see what they did with remote patient monitoring, nothing. This is the only real discussion of care management services in the proposed rule. So no other changes in those programs that complement this, for what it's worth. All those questions we have about CCM and RPM and how we do this and how we do that, those still all remain questions with the publication of the proposed rule.
Absolutely. And then, of course, they ask for comments. Some of them, you know, drive off of the state Medicaid. You know, how are they going to cover the QMB cost sharing? What about how they are describing the level 3 using a QMB status and multiple chronic conditions as the basis for billing the level 3? Do they need to consider other practitioners who may be in other CMS care models? You know, overall, what they are looking for is comments on this program, the elements that are included, the capabilities that are required. They want to know what needs to be modified, what needs to be removed. So I encourage you to please, please, please comment if it's in your wheelhouse and it applies to your services. So, all right, let's move on to telehealth. And of course, Martie so graciously explained that we're about to fall off a cliff with the removal of the geographical and behavioral, non-behavioral medical services going away at the end of 24. But to reiterate, that is a Congress ability to expand those services. CMS does not have power over that to correct it. So when we move to the next slide, when I say continue the use of the current E&M codes on the Medicare telehealth services list, I am talking about the telehealth behavioral E&M services, which will continue. It will be important to ensure that you are using the place of service code to indicate the location of the beneficiary, as well as an applicable modifier if it is an audio only technology that you are using.
Of course, Miriam, you would have the
ahead.
ability to use it in a rural area, right? So the rural, you saw the rural ability that you had prior to the waivers, but with the waivers gone, the only thing that we add after that is behavioral health ability, right?
It's, don't forget location, because it's no longer in the patient's home. They have to be physically present at a facility at the time the service is delivered.
Right.
Unless it's telebehavioral health, that's now carved out from the geographic and location restrictions.
Yeah, barring congressional action.
And it's interesting because, like, you read this and CMS, and then like the public, the public press release about the rule. If you read the rule, they just really don't talk about the cliff. They don't talk about the end of these flexibilities. They're basically, I've said this a couple of times, like they're rearranging the deck chairs in the Titanic. Dealing with these details within telehealth without recognition that the big change is coming.
Yeah.
I'm sorry, Miriam, we're interrupting you. Sorry.
No, this is an important piece because it will impact millions of claims that, I mean, you saw the graph. It's a lot of claims that are being continuing since the end of the pandemic, that we are continuing to use telehealth services. Have providers gone back to see patients in person? Absolutely, they have. But they are still utilizing telehealth to the benefit of the patients. And I think that's the key point, is patients need the care and we need to provide that ability to give it to them. Just me on my soapbox. Okay. They also are including a new code, the 9X091. Well, where did that come from? Well, it was part of a 2023 development of E&M codes, specifically for telehealth services. But CMS said, well, we're not going to use those because we already have the regular E&Ms. We can just add place of service codes and modifiers to get what we need. So they never did implement these. However, there is one code on there that is indicative of a virtual check-in. It also mirrors the G2012 code, which is currently in place. So they're basically going to replace the G2012 with the 9X091. That's it. It's just a change. And then, of course, the 99441 to 99443, which are the telephone E&M services, those codes will go away at the end of 2024, and you will continue to use the current E&M codes that are on the telehealth services list. Okay. Additions and deletions. There's always additions and deletions. And just to remember, there's two types of services that are on the telehealth services list. You've got permanent services and you have provisional services. So the codes that are the ones I'm talking about currently that are listed on here were provisional, and they are going to continue to be provisional because CMS hasn't had time to complete their comprehensive analysis, which is what they say they have to do in order to move a code from provisional to permanent. They have also added the home, the INR codes and monitoring in order to, and it is provisional as well. It's not permanent, it's added as provisional, and they're going to be monitoring the use of that and the effectiveness of that, as well as caregiver training. Caregiver training is several codes intended, as it says, for the caregiver without the patient present in order to perform these services under telehealth. And then they are removing the radiation treatment management code, which was provisional on the list, but they are now removing it to say that it has created a patient safety issue, and they are no longer going to allow that on the list of telehealth services.
I know we're getting close to the end of time. We need to do the RHC piece first, but I think this is really key that we have a process now to identify, to look at the data, to look at the efficacy of the process of the telehealth service, and to say, should we put it on the chopping block or should we not? And then if we need to remove it, we can remove it. So maybe Congress will feel more, like that they can move forward and allow us to make decisions about this and make sure that everything's going to be safe, that ultimately we have a process to confirm that. And so hopefully they will act. And there are several bills on the floor to move this forward. So hopefully we will see a shift and change to the actual rule that will allow us to do telehealth in the future.
But again, 2025, these are just services that can be delivered to a resident of a rural area present at a facility at the time the service is being delivered. This is just CMS using its authority to develop the telehealth list, which is granted under Section 1834M, but otherwise it's in a box.
Yep. A couple of additional things that they are doing. They are extending the frequency limitations on subsequent care services, both in an inpatient nursing facility and critical care consultations. They are allowing audio only to go into the definition of interactive telecommunication systems, which previously included audio and video as part of that definition. However, it is only applicable if the provider has the ability to do audio and video. However, the patient is in their home, does not have the ability or does not consent to using video technology. And then lastly on this slide is to allow distant providers to continue using their enrolled practice location rather than their home location for telehealth services through 2025. Next is direct supervision. So CMS is continuing to permit direct supervision for certain diagnostic services that are defined by the presence and immediate availability of the supervising practitioner through audiovisual telecommunications through the end of 2025. It does not mean that the physician or the supervising provider be present in the room when the service is performed. However, it does not include audio only, and that's a distinction that they clearly make on that. And as a reminder, in 2021, they expanded qualified NPPs to be able to do that supervision of those certain diagnostic tests as long as it fell within their scope of practice in their state. And then lastly, go ahead.
Sorry, real quick question. I don't know if Martie, Miriam, you know, but with the cliff potentially happening, is direct supervision under the telehealth provision, or is it outside such that this would still be allowed for your cardiac rehab and your other OPPS, hospital outpatient scenarios where you have direct supervision virtually right now?
Yeah, this is a change. This is CMS authority on its own to redefine how you accomplish direct supervision. The same with those, the frequency of how often you can use telehealth to perform a particular service. That's also within their purview. So it's sort of, you have to constantly figuring out what can they do, what can I not do, what can I do, what can they do. But these are, and when we get to RHCs, we'll go, they can do that. But
Okay. And then lastly is teaching physicians, which is continuing to extend the ability of the supervising teaching physician to be able to do their services virtually. And an example is, the patient is in one location, the resident is in another location, and the teaching physician is in another location. They can do that through a three-way telehealth. Audio video does say that. Audio only does not apply. And so I think that is all of the telehealth for today. I think you're going to talk about it too in RHC.
I do. So stick with, even if you're not an RHC or an FQHC, stick with us for a few minutes because they did some really interesting things here, which I think are potentially tell us where they're going with other things on the fee schedule. Every year we do RHCs and FQHCs as part of the physician fee schedule, even though for the most part they're not paid on the fee schedule because they're paid at the RHC and FQHC reimbursement, which is actually a Part A benefit. But they made some significant changes starting with care management. So RHCs, FQHCs have billed for what they refer to as general care management services under GO 511. Presently, there are a number of services that are defined on the fee schedule, and CMS said if an FQ or an RHC provides this service, rather than billing that on the fee schedule, they bill this GO 511, and they're paid at a rate that is a weighted average of the services that are included within general care management for RHCs. And this year it's right at about $73. There's a separate code that they're allowed to bill for psychiatric comprehensive care model, which reimburses closer to the fee schedule rate. What CMS proposes is to get rid of GO 511 and have RHCs and FQHCs instead submit the claims under the CPT codes and be paid at the national payment rate at the non-facility rate. So it won't vary based on where the RHC and FQHC is located. It will always be at the national payment rate. They are also asking, are there other things that FQHCs and RHCs do besides care management services that we have either rolled into the encounter rate that we should roll out of the encounter rate and allow them to bill for separately on the fee schedule? So if you're in that world, paying attention there. Question is this a good or a bad thing? And CMS notes that, well, yeah, we get it. There are some services that we reimburse under GO 511 that are paid at a lower rate than that national average. But what we're offering you is the chance for those services that have an add-on code for additional time, you now will be able to bill for that. That's always sort of been a sore spot. If you provide 40 minutes of chronic care management services in an RHC, you're still only billing 1 unit of GO 511. What they're saying now is you'd be able to bill that add-on code. So I just gave you some examples here. Again, this is from 2024B, what GO 511 is paying now. Compare that to 99490, which is the CCM code. And with the add-on code, if you're doing 40 minutes, you'll be ahead of the game. By comparison, if you're doing remote monitoring and you've been billing that remote monthly monitoring fee, that should actually be 99454, excuse me, it only pays $47. So you're now going to be around $25 short because you're billing that as an RHC under the CPT codes as opposed to having billed under 90511. The other question we didn't answer is the copayment issue, because copayments in RHCs and FQHCs are based on charges, which is different than under the fee schedule when the copay is 20% of the allowed amount under the fee schedule. And CMS didn't ask the question, what are you going to do, RHCs and FQs? So that is at least one comment I will be personally submitting saying clarify that, because otherwise we don't know how to do any of this. Next thing they did is telehealth, and this is interesting. They went back and said, telebehavioral health services, we treat that as an RHC encounter or an FQHC encounter. It's paid at the encounter rate. And they did elect to continue through 2025 a delay in the in-person visit prerequisite for providing telebehavioral health services. If you recall, when we expanded the telehealth benefit for telebehavioral health services, require that there be a face-to-face encounter within 6 months of the initiation of behavioral health services. That's been delayed because of the telehealth rules. Now it's coming back into effect, but they decide for RHCs and FQHCs to delay that by a year. For non-behavioral health services, for the medical services, interestingly, our RHC and FQHCs can continue to bill for that. That they'll bill that under G 2025 with the national payment rate. So instead of billing by CPT code, they just bill G 2025. The payment rate currently of that sits at about $96, so generally lower than the encounter rate that RHCs and FQs receive, but they will continue to do that for at least through 2025, soliciting additional input on what should be due, whether they should continue that in a different model. And they also note that we'll continue direct supervision for services in an RHC and FQ as much the same as they do on the fee schedule as well. Vaccination rules changing significantly for RHCs and FQHCs. They previously billed this through the cost report because they were guaranteed 100% of reasonable costs for pneumonia, influenza and COVID-19 vaccinations. Now, instead, they're going to be billing at time of service, and the MAC will reimburse that at the established rate for vaccination and vaccination administration. We'll still be doing an annual reconciliation. So you'll be paid on a fee-for-service basis, but with a reconciliation at the end to make sure that you're paid 100% of your reasonable costs. What is interesting here is Hep B, because Hep B has not been included in the services previously reimbursed into that cost report schedule. The question now is, are we also going to include Hep B on that? There's another opportunity for comment for our RHCs and FQHCs. Then there's a change in the conditions of coverage or certification for rural health clinics. We've previously had a rule that RHCs are supposed to be primarily engaged in delivery of primary care services, and CMS has said, well, that means that at least 50% more than 50% of the time an RHC is open, it needs to be providing primary care services, and that has always been a head scratcher. For RHC, it's like, well, what if we've got a specialist and a primary care physician on site? How do we count that? And finally, thank goodness, CMS said, yeah, we're done. We're getting rid of that requirement. We're no longer going to enforce it because they note that the statute does not specifically require that RHCs be engaged primarily in primary care services. They have to provide primary care services, but that word primarily is something that CMS admitted that they read into the statute. Do you smell a little Loper Bright going on here? Is this CMS finally saying, oh, we actually need to follow the statutory language more closely or find ourselves in litigation, which we know that's coming with the end of Chevron. Also note that they've made some changes to the required CLIA waived lab tests that an RHC must provide by changing some of the language as well as forward. In other news, there's other changes for RHCs and FQHCs on intensive outpatient rehab program. They have eliminated the RHC productivity standards. Woohoo! Another great going forward for our RHC friends. They are now in a really long, and I must admit, boring discussion. CMS is rebasing the FQHC market basket, moving it from 2017 to 2022, and then also some clarifications on dental services provided in FQHC. So a lot here for our friends in our RHCs and FQHCs to take attention to and comment on. So finally, once again, reminder that we have 2 more bites at the apple when it comes to the fee schedule. Also, right after Labor Day, we'll dive into the 2025 final rules. I think the home health final rule was published yesterday, so they'll start coming out quick and furious. So hope you'll be able to join us on the 14th and the 21st. We'll keep working our way or whacking our way through this proposed rule. Miriam, Valerie, thanks so much for joining us, and we'll see you in a couple of weeks. So Jennifer, back to you.
Thank you for listening to this PYA webinar recast. The video recording, slides, and associated material for this and all PYA webinars are available on our website. If you have any questions or if we can help, please contact us at pyapc.com. Thank you again for joining us and have a great rest of your day.